Hi there, welcome back to Ask the Chiropractor, your source for ultimate health, healing, chiropractic, and medical related information. I'm Dr. Adam Rodnick out of Commerce Township, and I'll be your host today. We have our two guests back with us again today. We have Dr. Jeff Lupo out of Roseville.
Hello.
And
Thank you.
Welcome. And we have Christine Bonds, who's the Director of Appropriations for Opioid Awareness for the state of Michigan.
Good to be here.
And I'd like to start off, Ms. Bonds, if you could just kind of share with us. I know it's a heartfelt story and it's very tragic, but if you could maybe share how you got into opioid awareness and why it's so close to your heart.
Sure, yeah, happy to. So in 2013, unfortunately, I lost my stepson to an opioid-related death. And it was not the first time he OD'd. He had OD'd twice before. And it was, devastating on many different levels because it really shakes the foundation of the family, and it's a very, very difficult place to be. I mean, grief is very personal, and so he was the eldest child of my husband, and so it was really sorting out, so much in order to just stay afloat during the time of his death and so forth. And he had been in treatment, and after a couple years, I really started to think about, like, what about the other families that are experiencing this? Like, have we really, as a community, addressed this problem? And this last year was when I truly couldn't sit on it anymore. I looked at the numbers and saw that, more folks in America had died from opioid-related deaths than the folks that we lost in Vietnam. And no one was talking about it. That was the weird thing to me. And so I started talking about it, and I went to Washington and met with some folks that had a lot of weight, and fortunately a year later now, in 2018, we've seen great strides made to not only let Americans know that this is an emergency, it's a crisis, that it's in your backyard, that your family's going to be affected by it, and as a community, what do we do to be in the solution?
Unfortunately, now we're seeing that more and more states are passing legislation to change the way the system has been the last decade, where they're limiting the number of prescriptions, the number of days doctors can prescribe opioids, number of prescriptions. They're increasing conservative care options. We were just talking about in the state of, I think, West Virginia.
Uh-huh.
They passed legislation that insurance carriers must cover at least 20 physical therapy visits or chiropractic visits, conservative care options, to make it eligible for these patients to have conservative care, instead of they don't have coverage, they may not have money to pay for conservative care. Their option was prescription opioids, prescription medication. That's the only option they had for their pain.
So the law now in West Virginia is the doctors send a conservative care before they would have opioids as an option for the patient?
Exactly. I think for certain conditions. And that was a state that I think they had the most problems, where there was literally almost as many prescriptions for opioids in a year than people in the state.
Yes.
People in the state, Wow. How is that even possible?
I don't know.
Yes, I know. And it's something that is very silent until it reaches, I think, a certain amount of folks, and
tipping point,
exactly.
Right?
And I think that we have reached a tipping point, and quite frankly, I think that each and every one of us can contribute to the solution, and that is getting honest about the dialogue. Really being just aware that there's probably someone that's very close to you that is either struggling with such a problem, and or someone that it could be a coworker, it could be a great aunt, whoever it is. It could be a neighbor, it could be a cousin, but just start having an honest dialogue, and that's, I really feel, the first step, because addiction, that word implies so much, and I I really feel that there's still a stigma to it, and it's really just a misunderstood disease and illness. It is an illness, and it should be treated like any other illness. It should be treated like diabetes or heart disease. And the great news is that we don't have to reinvent the wheel. We have enough research to show that we can offer a solution to any addict who needs help. And we now have the appropriate attention. We have the nation looking at this now.
And there's a few ways it starts, right? Some people start their addiction where it wasn't prescribed, where they bought it on the streets, where it was
Sure.
moving through the schools. And then there's a few ways it starts where it was prescribed, either acute or chronic. Acute, we were talking about that it's, sports injuries, oral surgeries, these type of things. They started with just a little bit. They took it for
Yeah.
a few days, just like that. Their body has formed an addiction. And then there's also the people that had chronic pain.
Yes.
And they are looking for options.
Yep.
They are in chronic pain, may have been in chronic pain for years, and so they're going through everything and anything that they can. So the more options available to them, the better, because their chronic pain may not just get better.
And what is chronic pain?
Yeah.
They had some sort of acute thing happen, and it never got solved.
May not have been
And it just-
addressed initially and got worse because
it
of
just
that, and now it's
persists.
become a chronic issue. And so some of these people will never be better.
Right.
They had a horrible, tragic fall off a roof. They had a horrible car accident. They can have improvement, but they
Yes.
may never be better. They may
100%,
never be
yeah.
the way they were before. And so they need options, things they can do at home therapy, home treatment options, things they can do, active and passive treatment with doctors, with chiropractors, with physical therapists. And the more options available to them, the less they may need to rely strictly on opioids for their daily life.
You mentioned before, like the United States takes or prescribes more opioids in this country than if you combine the rest of the world. I mean,
That's right.
What are they doing in the rest of the world?
What's
It's not
going
like
on?
they're
There
suffering
has to be
compared to
some-
us, right?
Right.
Yeah.
And unfortunately, and this began, if we were to take like a, history lesson, the opioids really they came on the scene like in the 90s, and they were supposedly safe drugs to take. They really were. Of course, there wasn't enough research to back that up, but we did some homework, and we were told that, they were safe drugs to take. And they were actually, in some cases, considered miracle drugs, especially for vets who
Wow.
were coming back and so forth. And what we didn't know is that the side effects are addiction. And so how do you address that? And we are at a tipping point now, and so fortunately we do have folks that really do care about allowing the communities to gain the resources they need to address this, monetarily, as well as putting new solutions in place. And I really think it also boils down to having a quality of life, because as you well know, taking these sorts of drugs does not necessarily improve your quality of life. And I think there's also a psychological element to it as well, because folks can be on low doses of these prescription drugs and they can't get off it, because I think psychologically, they
need it.
Exactly. So I think that, moving forward, approaching this from a very, 360 point of view makes a lot of sense. And again, I think the focus should not just be on the individuals who are suffering from taking these, pills chronically, but also the younger adults that haven't started yet. And as communities, how are we going to save these kids from even taking it for the first time?
And with your stepson, what did you notice as a non-physician, as a layperson, how when he was on, it affected his personality or his daily life? Because the other thing is, you could say, well, if it's so hard to get off, they could just keep taking it, no big deal.
Right,
if they feel good,
Yes.
they can function.
Yes.
But how does it affect their functionality for a young adult to be on these type of medications?
Yeah, so that's a great question, because it doesn't just have to be through death that we're affected, right? Their personality does change. I noticed right off the bat, and I think maybe it was because I just kind of took a step back and saw that, behaviorally speaking, he wasn't himself. I think it showed in his inability to consistently make some right decisions. A young man of his age had everything to look forward to. I mean, he died a week before his 25th birthday, and it got away from him. I mean, I think that that's part of the real tragedy is that he was such a bright young man, yet it fooled him. The drug fooled him, and he actually OD'd from methadone, which is given to patients that are
to get off.
Exactly, and so again, the awareness play is so important in this equation, because I feel like unless you've experienced it, you can read it in a textbook if you're someone that's a counselor or someone, but if you've really experienced it, you can see it firsthand that, he was given a drug that supposedly was going to be helping him, and quite frankly, that's what killed him. So being honest, having this honest dialogue, right, raises the awareness, and then we start appropriately addressing, different demographics in our communities and ultimately our nation.
And it really has. Awareness has been raised within the last year or two. Even the common layperson has just heard more about it in the news, in the media, on shows like we have right now. It's definitely getting out there, and like you said, it kind of hit a tipping point.
Yep.
Because it's not like this just started last year,
right?
Or started
That's
2 years ago. This has been going on for a long time.
That's right.
It just built up to a certain level, a certain amount of people affected, a certain amount of deaths, where they can see such changes in the whole healthcare system.
It keeps increasing till it affects basically everybody knows somebody or somebody is experiencing it.
Exactly.
So now you had a study that you were going to share with us
this is
again about some
2018,
treatment options that are in the conservative world for chronic pain patients that can limit the use of prescription opioids.
This is a 2018 study, so it's recent, Whedon et al. And they were discussing how pain relief, because now we're chiropractors, ask the chiropractor, and we're talking about one of the primary reasons people do get prescribed opioids is because of some sort of spine pain. And they're talking about pain relief resulting from services delivered by chiropractors may allow patients to use lower or less frequent doses of opioids. That's the heading in the right direction, leading to reduced risk of adverse effects. And they were trying to evaluate the association between the utilization of chiropractic services and the use of prescription opioids to see if there's some sort of correlation. And the conclusion was it was reported that the supply of chiropractors, as well as spending on spinal manipulative therapy, which you mentioned, like the coverage for their insurance, was inversely correlated with opioid prescriptions in the younger Medicare beneficiaries. So the younger.
So let's explain what that means then.
So the more there was chiropractic care available in a given area, there was less opioid prescriptions.
And that's just availability, and that's not even usage.
Yeah, that's just available. If somebody chooses to do that, they could choose them themselves. There was no requirement to do it. But just by having that available, it says the findings suggest that increased availability and utilization of chiropractic services could lead to reductions in opioid prescriptions. And that's basically addressing what you're saying.
Yes.
I know we have to, with the 2 to 20%, we have to improve that statistic about the people that are already suffering. But as far as maybe we could stop this in the beginning.
Right.
And that's the thing that's really good about that is, then let's say the conservative treatment fails. Then those are more of the actual candidates who were the right person at the right time
really
for that prescription. Right.
Makes sense.
Ruling out all the ones that were just automatic.
Yes.
So, and then there's other conservative treatment options. And we'll talk briefly about a procedure that we do, and we've been seeing some amazing results with a lot of chronic pain patients, with people with things like fibromyalgia or frozen shoulders or chronic torticollis. And it's just another treatment option when in-office conservative treatment may have plateaued. We see patients that may have done a certain amount of physical therapy and it helped them to a certain spot, and then they plateaued and they're a chronic patient. They've done a certain amount of chiropractic adjustments in the office, and then they start to plateau. They've had injections that help them spring back a little, but same thing, plateaued. Even prescription medication, right? It's not like the opioids get them better.
No.
Right? Or get them fully functional back into their activities of daily living or their active life. Whatever happened, they got on opioids to manage the pain. And it's only managing or masking the pain, not getting them back to activities of daily living. So again, plateauing. So
Well, I was going to say, this was a personal family story to me as well, where we had family member, car wreck, they're just sitting at a stoplight. I mean, we've heard these before where they're rammed in at 50 miles an hour.
Yeah.
And the neck problems that were there, it was going on for, like you named, every treatment you named, going through, and this is going on for 16 months. What else are we going to do? What else options are there? And of course, we're doing everything to avoid opioids. And so I guess maybe you could lead into what
yeah, so Dr. Lupo, you know, is a chiropractor like myself, and this is his own sister that he's talking about, and who also is a chiropractor. So she tried as much as she could in the realm of conservative treatment. And then we brought her into another arena where we do a procedure as chiropractors, but it's a medical procedure that we do with medical doctors and orthopedic surgeons as well, and we perform manipulation under anesthesia for chronic pain patients. Amongst a number of other conditions, like I said, like fibromyalgia, like chronic torticollis, like herniated discs. And so normal muscle fibers should be able to stretch to 120% of resting length. All of the muscles should stretch more than even the resting length. But what happens is the body, in compensation to maybe some sort of injury, goes into a state of spasm, the muscle spasms, muscle tightens, eventually becomes muscle splinting and or contracture. The muscles just don't move properly anymore. There's some segmental and somatic dysfunction to the joint or the muscles. Now, proliferation of fibrotic tissue or scar tissue is a normal part of the healing process. Like if I was to cut my arm or my hand, scar tissue forms right away. But you know, the scar tissue is more painful than regular tissue. It has 10 times more pain fibers and nerve endings. It just doesn't move right.
less functional too.
So when there's trauma to a joint, whether it's something like a sports injury, a fall, a trauma of some sort, a fight, a car accident, it's not like you just hit in one spot. You know, the whole body is shaken up. So scar tissue and fibrotic proliferation happens intramuscularly and intra-articularly between the joints. So if normal muscle fibers slide in and out like this, eventually now they're moving like this. They're not moving right. So with this particular procedure that we do, through passive stretching with continued linear force, allows what's called the GTO, or Golgi tendon organ, which is a proprioceptive nerve ending at the muscular-tendinous junction of a muscle, to relax. And in English, in regular terms, that's just the muscle's very tight and it can't relax. It's contracted.
Involuntarily.
Involuntarily. So we do this procedure with some passive stretching under anesthesia to allow the muscles to lengthen and to alter or essentially break up the scar tissue and adhesion. So we'll just show a little video about what this procedure is and what it can do for some of these type of patients.
So in December, I was in a car accident and I was driving over an icy bridge and I was T-boned by another driver. I slid right into the guardrail. I'm really excited about having the next step, the procedure done. Right now, I can turn my neck right about here is where it starts to hurt, and then if I go to the left, it's even less mobility. If I go to the side, I'm right about there, and then right about there. So I'm hoping after this procedure, I'll be able to turn my neck a little bit further, if not all the way.
So what I'm going to do right now, I'm going to lift your leg up here with call this a straight leg raiser. Now I want you to let me know when it starts to hurt. At some point it's going to immediately hurt in your back or your leg. We're going to go nice and slow, okay? When I come up here, you already start feeling it in the back. So what we're going to do when you're sleeping, again, the postural guarding muscles won't be active, so we're going to basically be able to fully restore the range of motion of the leg. It's going to stretch the sciatic nerve and the muscles of the lower back. So when you wake up, we should be able to bring this leg all the way up to 90 degrees, which is normal for a straight leg raiser.
All right, so we're gonna go together. Which part of the neck, right or left? Which is worse? When you turn your neck to the right or left, which is worse? Can you turn it for
She's
me
getting
now?
the form now.
Because I'm gonna ask you to do that after you should be able to go all the way.
We're going to stop there. Sideways, really tilting like this.
I'm Dr. Sam Hankey, orthopedic surgeon, and today we have cases to do manipulation of the spine, the neck, the back, and also the pelvis. Our main aim is to improve the range of motion and of course to reduce the pain. We're publishing this, so The patient is going to fill the form while we're talking now of subjective findings and complaints and restriction of range of motion and level of pain and level of activities that they lack. And then after the manipulation, we're going to give the same form to the patient. And then we add to the subjective, the objective findings that we will also do, where we expect the range of motion of the neck to be better and the range of motion of the back to be better, and the straight leg raising, the SLR, has to improve if we, of course, do a good job, which we believe we will. Look at it, 100%.
Hi, I'm Dr. Adam Radnick. Today we're going to talk about the manipulation under anesthesia procedure.
If you could come here and do it this way, come this here.
Today we're going to talk about choosing proper candidates for manipulation under anesthesia. We'll show you and talk about the procedure itself and what it entails, as well as post-procedure rehab.
In the office setting, her lateral flexion was severely restricted. We couldn't really get it moving past a certain degree. And as we take her into flexion, Dr. Lupo is going to put posterior pressure on the shoulders to restore the normal flexion and articular motion in the cervical spine. To get the lower part of the cervical region, upper thoracic region, I'll put my arms underneath.
Ready. Next patient for OR 1.
Under anesthesia without postural guarding motions.
This is a procedure for patients that have plateaued or have had failure to respond to conservative care in an office setting, such as chiropractic care, physical therapy, interventional pain management, injections, and medications, for at least 6 to 8 weeks of continuous conservative care. This is a procedure for people with chronic or recurrent pain, pain so severe that narcotic analgesics are of little benefit. This procedure requires 2 physicians that are specifically trained in manipulation under anesthesia. The procedure entails pressure and counterpressure. When one of the physicians is applying axial traction, the other physician is applying counter pressure.
So I really think that the manipulation of anesthesia works well, the combination of having multidisciplinary collaboration to do a manipulation of pretty well every major muscle group in the body is critical to restoring function in patients that have had injuries or loss of motion, secondary arthritis, and a number of other host of things that I've seen the results have been pretty impressive. What do you guys think?
We've seen a significant gain in function for the patient. I think that's the most important thing. We're restoring the range of motion, decreasing the pain, which are obviously really good things, but the patients have been able to function at a higher level than they were before they had their injuries or fibromyalgia or different various conditions that we've been able to help treat.
Patients have been under treatment already, and they kind of get to a plateau with physical therapy and chiropractic, and
And what we do is injections and so on, and really when we max out there, we need some more help because by then, the myofascial scar tissue has occurred, and this is where this collaboration really works well.
And some of these patients aren't surgical candidates or don't want to have surgery, or even a lot of them are already failed surgery. And so this is another great option for a lot of these patients.
Absolutely, and the rehabilitation has been very impressive. Most of the patients are up and walking right away, and within a couple of days they come and see us in the clinic. It's been phenomenal to see them back. Almost at 90% of the previous, trauma or prior to trauma injury, which has been great. Their sleep is better, and they're able to really reconstitute their quality of life.
And the reduction of the meds that they don't need to have anymore.
Yes, absolutely, especially with what's going on with the opioid epidemic. I think this is a great way of monitoring, getting pain under control, restoring function without having to go to the extreme of surgery and needing more.
Nearly all the patients in here have not had the pain shots afterwards.
Yeah, no, absolutely. And we've had over 95%, 96% success rate. One or two had to come back, but it was, again, they saw it because it helped them a lot and they had another re-injury of some form. And that also even worked well, even as a repeat procedure. That was phenomenal as well. So it was great.
Does a great job. Look at that. Beautiful. So you don't have to put the pressure.
There's no flinching with it.
So if you just do the neck now. I just go what I feel is, I'll go from as far down.
He's usually accommodating the sternum body
Push it down and up. See how it's moving? and it's pretty flexible. Then I do my flexion, or it's coming automatically. Sometimes it resists me, and it's basically falling. So then a little bit of slight flexion, and that's it. So it's moving, and I'm putting my thumbs on it. Perfect. Done. It's done.
All done? Yeah.
How's it going?
So what do you notice so far, Renee?
I have a lot more mobility. I can turn my head
Awesome.
a whole bunch more.
You can move a lot freer and easier, right? And you don't feel a lot of pain or soreness right now in the neck and back, right?
Not at all.
Awesome. And it's like I said, the
Great.
adhesion itself is avascular, so it doesn't have its own blood supply, so it doesn't hurt once we alter that adhesion.
Very good.
Great.
All right.
So this is a day and 1 week post MUA procedure. How you feeling now, Renee?
I feel great.
Awesome. Let's go ahead and let's see your motion in your neck now. So she's turning full motion, which is awesome. And there she goes, backward, forward. Let's do tilting, like your ear to your shoulder. And the other way. Awesome. The results from this procedure can be incredible. We have helped countless people get their lives back. So as you can see, there's some really great conservative care options for patients, aside from just prescription medication for pain, like the opioids. And then something like this procedure that we were just talking about and just showing is also a really great option prior to more invasive surgeries. We have some really great rapport with, like I said, the orthopedic surgeons who do perform surgeries, and we make referrals for those surgeries all the time, but something like this conservative care should always be ruled out before going to more invasive things.
And that patient's example was she was trying to see if she could avoid more injections and more invasive, more serious drugs like opioids.
In long-term use of opioids wouldn't necessarily be considered. It's not invasive, but what we're seeing now is that it is not necessarily invasive, but more invasive than conservative treatment options for the patients.
It's a fantastic example of how important it is that as a community we really start to value the alternative choices that are out there. The opioid crisis has cost this nation billions of dollars, and this is a great example of what can not only be prevented, but again, it goes back to the quality of life that now she's able to lead utilizing a very, very safe alternative method.
And she's still now, this is 6 months out, she's doing amazing. Had we not done this procedure, would she potentially have been someone who was on long-term use of opioid medication? I believe she potentially would have been.
Right, and so we really, with that example, treated not just the symptom, but the root,
cause.
the
Why
cause.
did this injury happen? And so
exactly.
a lot of the really important part is diagnostics as well. And that's one reason why we use a lot of great technology in our office. We use digital motion x-ray, so we can take a video and see what it looks like inside, whether it's a shoulder or a neck. We can see individually what is causing this dysfunction and how can we get it better in the fastest amount of time for that patient so that they don't feel like they need to have something else like an opioid prescription, or that the doctors don't need to prescribe the opioid prescription because we can just get them better.
Yeah, and
I was going to say, not everybody needs to go through that type of procedure to alter the trajectory of their life, get it back on track either. We see people all the time where
They come in, a couple of chiropractic adjustments, better, back to what they were doing before. And so we want to start with the very least invasive type of treatment options, even sometimes before even diagnostics. We do the diagnostics, but before we need to necessarily send for an MRI, we may be able to treat conservatively first, see how they respond, then we send for an MRI, and then we continue to treat conservatively, but also send to an interventional pain specialist who may use joint injections, epidural steroid injections. And then if that's not working, they're plateauing on that, then we send for the orthopedic or neurosurgeon to do a consultation. Then this procedure we just talked about, MUA, fits right in the middle there, and then eventually the most invasive, which would be the surgery. But oftentimes, again, Does the surgery fix them? Oftentimes, yes. And so, do they need long-term use of painkillers, opioids? No, because the problem is fixed.
Right.
You know, the tendon is reattached, the
Right.
disc is removed. The cause, whether we fix it conservatively, moderately invasively, or more invasively, is where we want to start. Is what is the cause? How do we fix it? Which way? Instead of masking it.
When it comes to spine pain, less than 5% are the type of things that you need to do surgery on. The majority, 95% is what you would need conservative things for.
Well, I mean, the body is always healing itself. It's always trying to heal itself. You know, that's a
power that
fact.
made the body heals the body,
Exactly.
right, yeah.
Until you know it's no longer. I mean, it is truly.
We just need to remove the barriers for entry for the body to do that. What it was trying to.
Exactly.
So I want to thank our audience for joining us today. That's all the time we have. This has been Ask the Chiropractor. Thank you to our guests for joining us again.
Thank you.
Stay healthy, Oakland County, and we'll see you next time.